Hi everybody, we're going to continue with the endocrine system, this time taking a look at the adrenal cortex and the medulla. So you may have learned before that the adrenal glands are glands found sitting atop the kidney, and each kidney, of course we have two, has its own adrenal gland. If we are to cut into the adrenal gland, we will find two separate types of tissue, a superficial outermost region of tissue called the adrenal cortex. It is glandular tissue, and what that means is it's a type of epithelial tissue or endocrine gland tissue. The deeper tissue is known as the medulla or medulla, and that's made up of nervous tissue. In the adrenal cortex, there are three layers there, and each one produces its own type of hormones. Each layer is called a zone or a zona, and so starting from the outermost layer, we have zona glomerulosa. It produces a class of hormones called mineralocorticoids. The middle region of cells produces glucocorticoids. Those middle region cells are called zona fasciculata. And finally, we have a deep layer called zona reticularis that produces sex hormones, otherwise known as gonatocorticoids. Let me give you a helpful hint here. You'll notice that these terms here are called corticoids, and I use that to remind myself that these are steroid hormones. Now, the prefix is also a great help. The mineral prefix here tells me that we're going to regulate some type of minerals in the bloodstream, perhaps things that have to do with sodium or even potassium. And that's just a short list that we'll be regulating. Let's do the next term, glucocorticoids. Corticoids say I'm a steroid hormone, and guess what we regulate? We regulate glucose or sugar. Last, we have gonatocorticoids, and of course corticoids say that these are steroid hormones, and they regulate the gonads or sex organs such as testes and ovaries. Another great built-in clue is this. The word cortex is in these words as well. Okay, so just a good reminder that these steroid hormones are in fact produced by the adrenal cortex. And because they're steroids, what type of messenger system do they use? The direct gene activation mechanism, or do they use the secondary messenger system to target their target cells? Well, we know that steroid hormones use what's called a direct gene activation mechanism, and that means that they travel directly into the cell and they find their intracellular receptor and bind. And at that point, protein synthesis can be turned on. In this picture, you can see the three zones, ZG, of course, being zona glomerulosa, the outermost region. Then you've got zona fasciculata and the reticularis layer making up the deepest portion of the cortex. You'll notice a transition here to a different tissue type. That's because the medulla is made up of what type of tissue? It's nervous tissue. So one thing to think about here is the adrenal gland cortex hormones regulate sugars, salts, and sex. So just kind of a funny way to keep it straight, but those prefixes, gluco, mineral, and of course gonatocorticoids, are what we're regulating. So if you're following me in your course pack, let's take a look at page 12 and now talk about what's in the middle of that page with mineralocorticoids. And instead of calling them mineralocorticoids from this point forward, I'm now going to focus on one particular one called aldosterone. So from this point forward, you're going to hear me specifically talk about only one mineralocorticoid, aldosterone. So one thing to take a look at here is, again, this word, aldosterone, and there's an "-one" ending there. That's another great reminder that we have a steroid hormone. And of course we knew that, right? Because corticoids are steroids produced by the adrenal cortex. So a couple of good words there to keep in mind. Now, interesting here that the aldosterone hormone targets its nearby neighbor, the kidney. So we know that all hormones travel through the bloodstream. So in fact, the aldosterone will hit the bloodstream and target its neighbor, the kidney. This particular hormone helps to maintain sodium and water balance. Specifically, it inserts sodium channels in the kidneys so that we reclaim more sodium from the forming urine. The water that follows does so passively. We know that water and salt play a role in regulating blood pressure. We know the more sodium you have in your bloodstream, the more water you will reclaim, and the higher blood pressure will go. So the job of aldosterone is to increase blood pressure. Okay, and the way it does that is by causing your body to retain sodium, and water will follow passively. We're going to learn later on in a coming chapter that water is the major influence over blood pressure. So if you want to increase water in your bloodstream, you do so by retaining sodium and letting water follow passively. Now this is an interesting point down here, the third bullet point. If sodium is reabsorbed by the kidneys, then potassium is released or dumped into the urine. Reabsorbed means that the sodium is moved from the forming urine back into the bloodstream. That's how we end up keeping that sodium. The potassium that is released, that ends up getting put into your urine, so we discard that extra potassium. That's aldosterone's role. It is to retain sodium from the forming urine, move it back into the bloodstream, let the potassium go into the urine. Now, just a thought here, what does water follow, the sodium or the potassium? Water follows that sodium, okay? So if aldosterone's in control, you not only retain sodium, water passively follows, and we end up increasing blood pressure. Just a reminder that way back in Bio 210, you probably talked about this animation, the sodium-potassium pump. It helps to maintain sodium and potassium concentration on either side of a membrane. That, in fact, is in use in the kidney during the time that we move out sodiums and potassiums across those membrane layers. So let's talk about what will increase or what will stimulate the release of aldosterone from the adrenal glands. Well, low blood pressure can do it, low blood volume, low blood sodium levels, or high blood potassium. So let me give you an example here. Let's say that you get up one morning, you've got an extremely busy morning, and you don't have an opportunity to eat or drink anything. Because you have not replenished lost fluids, then you may have low blood pressure, low blood volume. So in those two situations, we may see an increase in aldosterone. So when you increase aldosterone levels to help take care of sodium and water retention by the kidney, what do you think happens to the urine output by the kidney? Well, if you're keeping water to maintain your blood pressure, you don't need to pee out that water. So that water is reclaimed back into the bloodstream, thereby decreasing your urine output. So the urine you do produce will be dark colored yellow. It will be smaller amounts than normal, and that's how you're going to know you're dehydrated and need to drink something. And then during this time, aldosterone is in control of keeping any water that you have along with the sodium. Remember here, water passively follows the sodium. It's the sodium that we're going to be recruiting back into the bloodstream through sodium channels. Now, high blood potassium levels can also encourage aldosterone secretion. During the time that you have high blood potassium levels, you're going to secrete potassium into the urine, but what will you also be keeping at the same time? You'll also be keeping sodium at the same time. So this is an unusual hormone. There are in fact 4 mechanisms that control aldosterone secretion from the adrenal cortex. We have something called the Renin-Angiotensin aldosterone mechanism. We'll talk through it first. But then there's also sodium levels that can encourage aldosterone secretion. In fact, if you have low sodium levels, that's a form of humoral stimulation, that will encourage aldosterone release. Your kidneys will then keep more sodium. Likewise, high potassium levels can also encourage aldosterone release. In this case, you will secrete more potassium into your urine, getting it out of the bloodstream. We seem to think that ACTH has less of an influence over aldosterone release than does the renin-angiotensin mechanism, but it can also still play a role. Now, thinking back, where is ACTH released from? That comes from your anterior pituitary gland. And so if you're under stress, that can encourage more ACTH to be released. And of course, the more ACTH you have, the more aldosterone release you'll have from that adrenal cortex. So we really think that the #1 mechanism for maintaining aldosterone release is this one here. It's the renin-angiotensin aldosterone mechanism. Let me walk you through the renin-angiotensin aldosterone mechanism. This one is something we will come back to later on in the urinary system. That's going to be pretty much toward the very end of this course. For now, we're going to just superficially talk about how this process works. So notice the stimulus for this mechanism. It's low blood sugar. Your kidney actually maintains a kind of a situation where it monitors blood sugar, or blood pressure rather. It is going to monitor blood pressure, and in the case of low blood pressure, it releases a chemical called renin. And renin actually travels to the liver. The liver is going to release something called angiotensin. And there's an angiotensin 1 and there's an angiotensin 2. And we use an enzyme called angiotensin converting enzyme, or ACE for short, to convert angiotensin 1 into angiotensin 2. We'll talk about those details later on in the urinary system. For now, let's focus on this role. Angiotensin comes back to the adrenal cortex and tells the adrenal cortex to release aldosterone. You know the story from here. What does aldosterone tell the kidneys to do? Increase sodium. That puts it back in the bloodstream from forming urine, and to secrete potassium into the urine, so dump out that potassium. We know that water follows passively when we retain sodium, so we will have water also follow back in, increasing that blood pressure. So this is a pretty complex mechanism. You've got to have a functional working pair of kidneys, or at least one that works. Your liver has to be involved, and your adrenal gland. So there's a lot going on here with this mechanism that starts with the stimulus, which is low blood pressure. And the effector, of course, is aldosterone coming from the adrenal glands that helps to increase that blood pressure back to normal. So this particular mechanism is a negative feedback mechanism that helps to maintain blood pressure, tweaking it within a narrow range of values. If in fact you're under stress, stress can also play a role in increasing blood pressure. We know that stress can cause high blood pressure, and this is how. Stress targets the hypothalamus. We know the hypothalamus produces this releasing hormone here called corticotropic releasing hormone. There's that word, cortico, right? That tells me I'm going to eventually send a message to the adrenal cortex. Corticotropic releasing hormone targets the anterior pituitary. Anterior pituitary releases this tropic hormone here called ACTH. AC is a great clue because that stands for adrenal cortex. Now, of course, the adrenal cortex targets the adrenal gland. The adrenal cortex stimulating hormone targets the adrenal gland, and it, of course, then in turn produces aldosterone. So if you're stressed out, this particular mechanism can override the renin-angiotensin aldosterone mechanism and end up causing you to produce more aldosterone. What is the main goal of aldosterone? It's to increase blood pressure, and it does so by retaining what at the kidney? By retaining salt, which is sodium. So reduce your stress, lower the amount of aldosterone. We know, however, that this is just one of 4 mechanisms that can increase aldosterone's release. Now, with all this talk about increasing blood pressure, there is one antagonist, and it's called atrial natriuretic peptide hormone, or ANP for short. Let's break this word down. Atria are chambers of the heart. Natri means sodium, natrium technically. A uretic or diuretic means it causes you to produce urine. Because it's a peptide hormone, that tells me it's a protein-based hormone, and it works by the secondary messenger system. A lot we can learn from the name of this hormone. This hormone is produced by the heart. It causes a loss of water, salt, and fat from the bloodstream, and its goal is to lower blood pressure. So how do you get rid of this stuff? You release water, salt, and fat into the urine. That will lower blood pressure. So here's the deal. If you look at this heart picture down below, these are the two atrial chambers right here. And if you happen to have high blood pressure, they can stretch. And of course, if they're stretching, these ventricles down below can also stretch. If you stretch out these particular chambers of the heart, then it can become large, flabby, and unable to operate as a pump. So in order to keep the heart from overworking itself from high blood pressure, ANP's job is to lower blood pressure. Okay, so that's going to help us work as an antagonist, meaning it's working opposite to aldosterone. So make a note here, this is the only hormone that helps to lower blood pressure. Only one, okay? There are others that help to increase blood pressure besides aldosterone, but this is the only one that helps to lower blood pressure. All right, that should take you to the bottom of page 12 in your course pack. Let's now turn our attention to the top of page 13. We're now going to talk about glucocorticoids in more detail. Just a reminder, corticoid means this is a steroid-based hormone, and also it's a hormone produced by the adrenal cortex. The word gluco here tells us we're regulating glucose or sugar in the bloodstream. So a lot can be learned from just looking at the name of this class of hormones. The one we're going to focus on is called cortisol. You've probably heard of a similar one called cortisone. Cortisone, of course, has that O-N-E suffix, same as aldosterone. Just a reminder, it is a steroid-based hormone. So most cells and tissues in your bodies have intracellular receptors for cortisol or cortisone. We know that the intracellular receptor is how we bind a particular target cell if we have a steroid-based hormone. So why might you use hydrocortisone at home? If you have it in your medicine cabinet, why might you use hydrocortisone? You probably put it on an itchy ant bite or maybe a mosquito bite that won't stop itching. It is a great topical or superficial cream that we may use as an anti-inflammatory. So that's probably what you're familiar with, right? This particular hormone, cortisol, has an anti-inflammatory role. In other words, it fights against the effects of the immune system. Now, what we're going to focus on is another job of this particular hormone, and that is this one here, gluconeogenesis. We know that gluco means glucose or sugar, neo means new, and genesis means to make. So this particular hormone encourages sugars to be made from things like proteins and fats. So we break down proteins and fats to make this particular sugar, glucose, for ATP production. So you're thinking, wait a minute, when I learned about glucose back in Bio 210, glucose is a simple sugar that normally makes more complex sugars called glycogen. Now, you're right in that aspect. Glucose is in fact a carbohydrate, and the storage form of it, glycogen, is also a carbohydrate. So you're probably wondering, how do we get proteins and fats into this conversation? Well, if you break down proteins and fats, you can eventually end up with glucose molecules. It's not the normal way to make glucose, but if you need that glucose for ATP, then you're going to break it down from anywhere you can get it. We are going to burn through glucose supplies first in the bloodstream, then we'll burn through those available glycogen storages in our liver and muscles. But eventually, after about a day or two, we're going to have to start breaking down fats and proteins to generate enough ATP to be able to operate. So we think of this particular hormone as a long-term sugar metabolism hormone. It maintains sugar metabolism when you're stressed out. Maybe perhaps you have a lot of things going on in your life. Someone's in the hospital. You have demands at work and at home that you're dealing with. This particular hormone says, okay, you're not eating on a regular basis, so in the meantime, we'll break down fats and proteins to ensure that you have enough glucose. Of course, we know that glucose is going to be used to make ATP. That's the link there that we're looking for. We know that stress can also encourage cortisol release, and it starts with the hypothalamus producing corticotropic releasing hormone. And of course, the anterior pituitary then responds by producing adrenocorticotropic stimulating hormone, or ACTH. ACTH targets the adrenal gland. It may encourage aldosterone and cortisol release, so you get a 2-for-1 here. You not only will get an increase in blood pressure, but you can also get an increase in blood sugar. That's because cortisol helps to increase glucose levels by breaking down what? Breaking down fats and proteins. What's the other effect of cortisol? The other effect of cortisol is anti-inflammatory. Okay, so it can also cause the immune system to be dampened while it is in control. Now, I don't want you to think bad things about cortisol because it is necessary. We produce small amounts of it at all times. It helps you to function. In fact, without cortisol, you won't feel very good at all. But do know here that cortisol does cause glucose levels to increase. That's why taking this particular hormone as, say, prednisone or another type of oral steroid can cause real problems for people who are diabetics because of that increase in glucose levels. Let's turn our attention to gonatocorticoids. They're about midway down page 13. Just a reminder that corticoids means that we are dealing with steroid hormones produced by the adrenal cortex. A lot of great clues hidden in that word. And we know that gonads are sex organs, so that means we're talking about ovaries or testes. Let's now turn our attention to some adrenal cortex disorders. They're on the bottom of page 13. We're going to talk about Addison's disease, Cushing's disease or syndrome, and finally masculinization. First of all, let me help you fill in the blanks in your course pack. Addison's disease is caused by a hyposecretion of aldosterone and or cortisol, while Cushing's disease is caused by hypersecretion, typically of cortisol. Let's talk about Addison's disease first. This typically comes from a lack of aldosterone and or cortisol. And with this insufficiency, we see a whole host of syndromes or symptoms such as weight loss. That's because we are now breaking down fats and proteins to make sugar. Because we're breaking down fats and proteins, we see muscle weakness. Because we don't have enough sugar to make our ATP molecules, we then of course have fatigue. Which hormone do you think is the reason we may have low blood pressure? That's aldosterone. And these top three here are due to the lack of cortisol. You may notice these last two things and think, well, they're kind of strange symptoms. Skin darkening is actually due to a melanocyte stimulating hormone. I'm just going to call it MSH for short. And that particular hormone comes from the brain, comes from the anterior pituitary, and it's involved in this mechanism here. So, interesting side effect is skin darkening that may come from Addison's disease. You may also see salt cravings called pica that cause a person to be interested in eating dirt, chalk, baking soda, other non-food items, even like cornstarch. And pregnant women may oftentimes have this if they have low levels of which hormone? Aldosterone. Why aldosterone? It's the one that regulates sodium concentration in the bloodstream. So you may have seen, these stranger addiction shows on TV that talk about people eating sofa cushions and whatnot. Sometimes those are psychiatric issues, but in the case of somebody craving these kinds of things that contain salt or sodium, they may in fact be wanting to replenish the sodium that their body is unable to hang on to. That condition's called pica. JFK was president back in the early 1960s, and color television was brand new at that time. People thought that were in his close circle, he might die from his medical conditions. Little did they know he would die from being assassinated in his position. But he was very tan. Let me show you this next picture, along with these dark spots that can form on your skin. So he had an all-over tanning effect where some people may have these dark spots that develop in odd places, like you see here. So, it's not necessarily that a person looks like they've been exposed full body to the sun, these strange deposits of pigmentation may develop elsewhere. Normally, we don't expose the gums in our mouth to the sun, so this would be a warning sign for potentially Addison's disease or even melanoma cancer. So skin darkening may be one aspect of Addison's disease. It is a warning sign for something going on with those adrenal glands. The opposite end of the spectrum is Cushing's disease. Cushing's comes from an excess of hypersecretion of cortisol. So cortisol increases blood glucose by breaking down what? Fats and proteins. So unfortunately, that can cause obesity. If you don't burn the glucose that's being broken down, then your body just simply stores it back as fat. Think about this. You may be lean and healthy with very little fat tissue. If you have Cushing's disease, then you may end up making more fat and less muscle simply due to the fact that your body breaks down your healthy protein muscle and stores it back as fat. So that accounts for these first 4 symptoms. Obesity, moon face is weight gain in the face, stretch marks and thin skin can come to increased cortisol, and buffalo hump on the back of the neck, this area right here, comes from the storage of fat in between the shoulder blades. So excess glucose can lead to a lot of problems, including high blood sugar. We also see some other issues develop. Irritability and anxiety and depression can come from some other hormones kicking in here, perhaps epinephrine. Hirsutism is male patterns of hair growth, especially concerning for a female. And again, bronzing of the skin comes from that melanocyte stimulating hormone that we do see involved in both of these particular disorders. I had a student many years ago with this condition, and she was thin, petite, and put herself on a diet before she got tested of tuna fish and crackers for 3 months because she couldn't understand what was happening with her body and wanted to try everything she could to limit her weight gain. When she finally got tested, she found out that she had excess cortisol, Cushing's disease, and for her condition, they went in and removed the anterior pituitary. So, of course, we know the anterior pituitary is up here in the brain, and it involves going through the nose, breaking a bone in the skull, and then going back into the brain and removing that pituitary gland. So the unfortunate thing is the pituitary regulates lots of different things in the body, all the way from growth to reproduction cycles. So doing this not just fixes Cushing's disease, but causes other problems that now must be maintained. Thinking about this, in addition to the pituitary gland, where else might somebody have a problem? Right here, adrenal gland. So if the problem is not the pituitary, the problem may in fact be the adrenal gland that's causing this issue. So in that situation, we may have to remove an adrenal tumor to stop Cushing's from happening. So a person with this condition may look like they have diabetes. It comes from an excess of weight gain. It may look like an insulin problem, but in fact, it's a cortisol problem. So Cushing's can be caused by medications that people take. Prednisone or other types of steroid medications may cause increased glucose levels in the body. And we also can have our own issues in our bodies. Pituitary tumors, adrenal gland tumors, both of those can cause increased cortisol levels and increased blood glucose levels. In this image, you can see a little boy that had Cushing's syndrome. This is typical moon face that we've talked about earlier that comes from the increased glucose, which is then again stored back as fat. He has apparently had some treatment, and you can see in the picture on the right, he has lost some of that weight. Another case here of Cushing's, of the little girl in this picture. And because Cushing's can come on quickly, it can cause a fast weight gain. And again, this is because fats and proteins are broken down through gluconeogenesis, and they form glucose. We'll talk about that process in a later chapter. If the glucose is not used, then the glucose can be stored back as glycogen, which is the storage form of glucose, and then back not as protein, but back as fat. So that's how we end up seeing weight gain and stretch marks come from this increase in glucose. Another case of drug-induced. This means this person was on some type of corticosteroid, maybe an immunosuppressant drug, because those are also corticosteroids. And you can see the stretch marks and the weight gain there. This is the buffalo hump that is seen on the back right here, and that comes from brown fat that is stored between the shoulder blades. Babies have that brown fat when they're born. It helps them to survive until mom's milk comes in, and that's really the only time it's important for us. But if we do develop Cushing's, we can actually store brown fat there between the shoulder blades, and that's what we call a buffalo hump. It's that hump of fat that is stored from this excess glucose breakdown from fats and proteins. Before and after, he probably had either pituitary gland surgery or adrenal gland surgery. And now let's turn our attention to masculinization in women, which is on the very bottom of page 13. We would not notice if a male had excess testosterone necessarily, but in a female it can cause dramatic changes. So masculinization is something that we tend to talk about specifically for females. The bearded lady was something that circuses had back in the day. This is in the 1800s and 1900s. And of course, not a joke here, but she had an adrenal gland problem. She either had an adrenal gland tumor or she had a pituitary gland tumor that caused her to hypersecrete testosterone. Now, the adrenals actually make small amounts of testosterone and estrogen. Those are the gonatocorticoids that target the testes and ovaries in both males and females. Let me be clear here. Males make both small amounts of estrogen and testosterone, as do females. So starting at birth, we make both sex hormones at the adrenal glands. And those are called gonatocorticoids because they have influence over the gonads, ovaries and testes. Another picture here of a woman with a beard. All right, and then finally this picture here is of a little girl that has an adrenal tumor. You can notice she's gone through puberty at age 3. So this is called precocious puberty. It needs to be halted because it not only can cause a female to start menstruating at this age, it can also cause her to stop growing because estrogens and testosterone can cause the long bones to stop growing. We know that from Bio 210, right? Those epiphyseal plates will harden as a person, a female here included, goes through puberty. Let's turn our attention now to the adrenal medulla. If you'll flip on over with me to page 14, we'll talk briefly about these two. Just a reminder, the medulla is the innermost nervous tissue of the adrenal gland. What you're looking at out here is the cortex region. That's what we just finished discussing. Now, that medulla is made up of nervous tissue, and this particular nervous tissue operates for the sympathetic nervous system. That's a branch of the autonomic nervous system. All right, so the adrenal medulla makes two hormones that are produced here. They're called epinephrine or adrenaline and norepinephrine or noradrenaline. These two hormones are released over a sympathetic nervous system pathway. But let's talk about the word hormone here for just a minute. Because I'm using the word hormone, not only do they travel over a sympathetic nervous system pathway, but they're ultimately released into the bloodstream. And that's how these particular hormones can cause a systemic response. We know that the epinephrine and norepinephrine hormones bring about a fight or flight response. We discussed this back in Bio 210 as well. We know this is the response of the sympathetic nervous system to things like emergency, excitement, exercise. And when we do have a fight or flight response, we see increased blood glucose levels, increased heart rate, increased blood pressure, dilation of the breathing passageways called bronchioles. That allows us to bring in more oxygen. So we also see a decrease in GI activity, so that means the gastrointestinal activities will slow down. Diuresis means the formation of urine. So this particular set of hormones will cause an increase to the thoracic cavity organs and a decrease to those abdominopelvic cavity organs. Okay, so this particular set of hormones causes increased blood glucose, heart rate, blood pressure, increases the passageways for the respiratory system, but decreases gastrointestinal and urinary activities. Just a great time to review here. There's been a lot of information in this particular chapter. We are now looking at the renin-angiotensin mechanism. Give you a moment to read here. Best answer for this one is low blood pressure. And one more. So 4 of these increase blood pressure, and only one, letter E, lowers blood pressure.